with unsteady gait. And what would you like to know of her?
The duration of her unsteady gait.
It's been going on for about 6 months.
Is it getting worse or staying the same?
She's not entirely sure, but she thinks if anything, it's probably getting worse.
Does she have any health problems?
Any what?
Any other pre-existing health issues?
No, healthy.
Does she drink alcohol?
She drinks an occasional sherry.
She's fine. No one drinks occasional sherry now.
She's not a smoker, no.
What does she mean by unsteady gait?
Yeah, so she just finds that balancing is difficult. She's running into things a little bit. She's tripped a couple of times, that sort of thing.
Does she have trouble with her feet, like controlling her feet, or is it more her whole
Maybe
leg,
that's
or-
what it is. She thinks that there may be a component of that.
Problems with writing?
A little bit, yes.
Small writing?
She has noticed that. She's got a bit of difficulty with filling in her checkbox, hitting the sort of just not very legible.
The arm swing is different in your...
She hasn't noticed that, but when you examine that, you do notice that her arm swing is a little bit worse on the right, as in not as much.
Three more.
She does have an occasional tremor. What do you want to know more about the tremor that she's got in her right hand? Are you going to ask her if it's an intention tremor? No, I'm the patient. What are you asking her? The tremor occurs at rest. Yes. So she doesn't have any problems holding things, but she notices that when she sits in the chair, she gets a tremor. So you're honing in very quickly on the problem. But for unsteady gait, what would be your differential? So that's the key one that I wanted to just elicit. So peripheral neuropathy should be something you consider. You all went very quickly for the Parkinson's disease, which is great, and definitely something to worry about. I find that peripheral neuropathy is more commonly missed because people don't think about it so much. So cerebellar, people seem to always think about cerebellar problems, which are not commonly the cause of gradually progressive gait unsteadiness. But peripheral neuropathy and Parkinson's are the more common issues. Other things you want to do when you examine your unsteady patient is you do want to look at extraocular motility. One, to look for nystagmus because of vertigo that can cause unsteadiness, although usually patients report that differently, right? When they talk about dizziness more in their head rather than walking problems, although not always. So you want to look for nystagmus. You do also want to look at eye movements in general. Do you know what it would mean if you have trouble with up and down gaze?
It's usually to do with your cerebellum.
Close.
Supernuclear gaze palsy?
Very good. And what does that suggest? What condition?
Is it philanthropy?
No. So there's a condition called progressive supranuclear palsy, or PSP, which is one of the Parkinson's plus syndromes that you probably haven't come across much, but it is in the differential for a Parkinson's disease. And the difference is that they have trouble with down gaze, particularly some up gaze problems. They're okay sideways, but they struggle with walking down steps because they cannot look down and they'll trip. They're quite stiff. They have more stiffness than tremor. So it's not something you need to necessarily remember, but that's one of the things you screen for when you do some extraocular motility tests.
With the Parkinson's plus syndromes, are these Parkinson's plus extra specific things?
Sort of. They don't have exactly Parkinson's and then extra things. They'll have some features of Parkinson's and then some extra things. So there's overlap. It's like a Venn diagram. So they're not Parkinson's and then there's other things that are around. They have share some features. They're all extrapyramidal syndromes affecting the basal ganglia in the brain. So they're all motor syndromes. They generally do not have a lot of sensory features. Having said that, one does. So don't want to talk too much about that. It's more to have, so you've heard of this. When we talk about these things as Parkinson's plus, these are the kind of conditions. Shy-Drager syndrome is where you have severe orthostatic hypotension is one of them, multiple system atrophy. So these are just the more bizarre things in neurology that we look at when we have somebody with Parkinson's disease. The other thing you want to do with, you want to check tone. So with Parkinson's disease, it's that cogwheel rigidity that's triggered by the tremor. So if you don't have a tremor, you won't get cogwheel rigidity. So it's just you're feeling the tremor. I'm testing, and I think I might just leave it at that. So Parkinson's disease, usually there will be a tremor. Usually it starts on one side. So that's really typical for Parkinson's disease. So focal onset eventually spreads to the other side. It tends to start in one limb. It can be the leg or the arm, and then eventually it spreads to the other parts, which is different than, for example, progressive supranuclear palsy, which is more symmetric and has more of a global stiffness. The tremor is worst at rest. It's differentiated from a benign essential tremor, which is really probably the biggest differential for Parkinson's, aside from the neuropathy. But with somebody who presents just with tremor, yeah, that's what you're excluding, right? The benign essential tremor, which gets better with your alcohol. And most people do report this. There are some people who don't drink at all, and then you don't want to start drinking just to test this, but you can give them some propranolol and see if the symptoms improve. There aren't a lot of things we test for. You can check for hyperthyroidism with tremor, but usually that's quite a different tremor. That's more a fine tremor. That's postural, like you're drinking lots of coffee, that kind of tremor. And then you have your cerebellar intention tremor, which is again different, which is when you're going onto the target, you're having more difficulty as you're getting closer to the target. So rest tremor with Parkinson's tends to be when they have their hands. So what I have them do is they're sitting, and I just have them relax their arms in their lap, maybe even close their eyes, and they starting their tremor. And when they're walking, and you have your arm swing on the left, and they pull up, and they have a little tremor on the side that's affected. Also, postural reflexes are good to check in Parkinson's disease. So you have the patient stand up, and you pull them slightly back, and they're doing that sort of thing. That's a good test for Parkinson's.
I vaguely remember one of the tests is to turn people around, and they take more steps as they're.
Yeah, so you can do that. I don't do that because I always worry I'll have people fall.
Right.
I'm relatively small. If I were sort of 6'4" and had a little old lady, then I wouldn't worry so much. But I find that quite unsafe. So what I do is, can I just get you? If you stand here. So even for a big male, if I test them, I put your feet together as much as you can. And then I'm going to pull you back, but I don't tell them when I do it. And then I can hold them like that, and they'll fall on me. So I like that a little bit better than if you have the uncontrolled turn.
Right,
Thank you.
okay.
Sorry, what does he do if he's got the Parkinson?
So that if he does the Parkinson, so if you pull back, you're stepping back a little bit. Yeah. Otherwise, you tell them, do try not to move your feet in part of the instruction. So somebody who has well-preserved postural reflexes, you're testing postural reflexes. They just go like that. That's the natural response. As far as diagnosis, there is no test, and I don't image people with Parkinson's disease. You can get vascular Parkinson's if you have a stroke in the basal ganglia. It's really rare. It would be sudden onset, and if the history doesn't give me that, I don't look for it. And the diagnosis is confirmed by response to dopamine. So that's really the only diagnostic test we have. As far as pitfalls, you need to be aware of impulse control disorders. Have you heard of this with dopamine agonists?
Yeah, compulsive gambling.
Yep, gambling, shopping, pornography. So these bizarre changes in personality that will not come to attention unless you ask for it. So you ask the patient and the spouse, after they've been on the dopamine agonist for a while, has anything changed? Is anything bizarre happening? And you can give some examples of the shopping or the gambling. And I have had patients, we've only known this for about 10, 15 years, and prior to that, I've had one patient who gambled away half their livelihood. So, you should always warn patients before you start dopamine agonists that this is a risk. It's not a very common thing, but it's common enough that it's very likely you'll have somebody experience this at some stage during your career.
Did you get to sign over the financial situation of their spouse? I had a few patients that have done that after advice from the neurologist.
Yeah, I think that's reasonable. I mean, usually though it's caught, if you, the only risk is if you don't tell anyone and you don't ask about it. It's not like they don't hang on to it and then become, psychotic and won't share their resources. I mean, once you explain it and then you stop the drug, it's immediately reversible. So I don't think it's quite that. I haven't recommended this to people, but certainly if they want to do that, that's fine. And then the non-motor symptoms that we all tend to forget about. We focus on the weakness and the stiffness and the tremor and the walking, but they get anxiety, they get depression, they get REM sleep disorders, they get loss of sense of smell, orthostatic changes. So there's a whole bunch of non-motor symptoms that it's worth just asking the patient how are they doing from a mood perspective and how are they coping. There's those other things. How's their sleep? You want to be aware of. Those are the drugs we use. You'll have seen all of them. I don't use much selegiline at all. I don't find it that helpful. I usually use the levodopa drugs or the ropinirole. I do like amantadine at times that you probably don't use much. It's a really mild, has a slight dopamine agonist activity. It's really well tolerated in general, but it can have the same problems as the other dopamine drugs, which can cause hallucinations after a while. So you want to be aware of that, but that's quite a good one for early treatment. And anticholinergics are not very much used at all, but they work quite well for tremor, predominant Parkinson's. And the only thing is, of course, they have the usual side effects like constipation and drowsiness. So generally we do start with these two. Sometimes we start with that, and then we go from there. We used to not start dopamine agonists or dopamine early because there was this idea that you run out of treatment. That's no longer the way we think of it. We just say, well, let's get quality of life as good as we can. There's no evidence that that the disease progression is any faster or you run out of medication effect sooner just because you start earlier. Once you start getting a lot of motor fluctuations, so that's usually what happens as the patient progresses, you have a shorter duration of benefit before you get these fluctuations of the dopamine. You take a lot of dopamine, it's dyskinetic, and then you freeze, right? And those episodes, at first it's sort of 4 hours before that happens, and it's 2 and 1, and so we increasingly reduce the dose and give it more frequently. And at some point, it just becomes really difficult to manage that, to have a smooth course over the course of the day. And deep brain stimulation is really good for that, for these people who have significant motor fluctuations. You can also do an infusion of dopamine into the stomach continuously. That's not done a lot of places, but it is something that is an option in some. So I think, so the last 2 cases that I had was a neuropathy case of a Guillain-Barré syndrome patient with ascending neuropathy. We've talked a lot about neuropathy, so I don't think we need to talk much more about that. Just wanted to show you nerve conduction studies. This is what we do. We put recording electrodes on the hand, stimulate at the elbow or at the wrist, and measure how long it takes. So this is the response we get. So here's the impulse, and then we see the response. This is how long it took for it to travel from there to there. And then we see the amplitude. This is how much signal got through. An EMG is fundamentally different from nerve conduction study, and it would be good for you to have an appreciation of that when you talk to patients what they're going for. So nerve conduction study checks the nerves. Electromyography checks the muscles. There's no electrical activity given to the patient with an EMG. An EMG is a needle examination done by doctors where we stick a very small needle the size of an acupuncture needle actually into the muscle, and we record the electrical activity inside the muscle. We record it at rest, and we can pick things up like fibrillation potentials, which is a lower motor neuron sign, counterpart to fasciculations. Fasciculations is something you see clinically, little twitches, or you might have had them after exercise. People with motor neuron disease get those. If they're not very overt clinically, we can look for fibrillations on EMG, and then we activate the muscle, and see how well it activates. And that gives an idea of both muscle health and also how well the nerves are connecting to the muscles. So we look for something called denervation. And I won't talk about that much, but it's a different test. And they go hand in hand, and we often do them at the same time, but they look at different things. So electromyography, myo is muscle, looks at muscles, and the nerve conduction study looks at the nerves. And the reason why I'm making a point of that is because I just want you to be aware, when you refer patients to us, often you'll say, can I get this nerve conduction study for this patient who has a left leg weakness, and I want to rule out a lumbar radiculopathy or something like that. Then I look at that and I say, well, actually what you want is an EMG. And I might triage it into an EMG clinic, which is a consultant clinic, and then you get a report from that and might get a full visit report with that. So I just want you to understand that. So we try to triage it appropriately. The more accurate your request is when it comes to us, the more efficient we are in triaging it because it goes to the right place. And if you don't get what you expected, that's why. Okay?
Excuse me, but a carpal tunnel, you're going to do a
Nerve conduction study, correct. Yeah, you don't generally need an EMG for that. And that's, so when you refer for EMG for carpal tunnel, we'll then put it into the technicians. Also, the technicians do the nerve conduction studies. We do the EMG bits.
Most people complain bitterly about nerve conduction studies. Is that?
Most people don't. I've
No,
only
most
just
don't.
realised that they actually do get a bit of shock. I've only ever had one patient who's ever mentioned that.
So
I've had
That's why
so
until
many
then I thought they were-
complain that I'm wondering, is this normal?
They were painless before that.
So
What should
having
I
done
do?
this for many years, I think there's huge variation between people.
Yeah.
In general, I find that it's also very operator dependent.
Yeah.
So it depends on the technician and the doctor doing the test, I find. So I always use very small, I use the smallest needle I can, but it sometimes means that especially if they're kind of big people, I need to then graduate to a bigger needle, which reduces efficiency in my testing. But I'm a very compassionate person and try to inflict as little pain as possible. Some people are more efficiency driven and might not quite have that same approach. But you know, there's pros and cons to both. And so it depends a little bit on the operator. There are techniques that hurt more with the needle than others, but it's actually usually the nerve conduction studies that bother people more than the needle examination. Even though when they come in, they're usually more worried about the needle examination. And the nerve conduction study, it also is a bit operator dependent and how high you go up. The bigger the person, the more stimulus you need, because you need to get through a lot of adipose tissue to stimulate the nerve, and that will hurt. But generally we do very similar things to all patients, and then it's a matter of pain threshold. And I've had patients stand up and leave. And you know, interestingly, my observation has been it's the motorcycle accident people with the tattoos all over who like say, I have enough of this and walk out, and then you get like this little old 90-year-old lady who's just toughing it out and it's fine. And so it's this, but that's just anecdotal. So
Is there any point in giving them anything ahead?
No. You don't want to give them anything because that affects the results. So you don't want them to sleep through it. It doesn't.
And Panadol wouldn't work.
No, because it's a different kind of pain. But it's really, it's not that bad. I mean, I've done it to myself. I've gone through it, and it's not pleasant, but it's completely tolerable. And I think preparing, and this is something you can do too when you send the patient, make them aware. A lot of it has to do with expectation. If they know they're getting these shocks, and the shocks don't actually hurt that much, it's more that it's quite disconcerting to get electrical shocks. You know, it doesn't feel good. It makes you feel like you're punished or something, and so it's just, you know, a lot has to do with how prepared you are and how ready you are. And some people just don't tolerate it, and you just accept that. But it's interesting that you've had different, you know. Where do you work?
Well, I've only just realised after 20 years, there was a patient recently who said, "Oh, it hurts." It's like, "Oh, really?" Because I've never had patients even mention it before then.
It's definitely not pleasant. But again, it also matters on what test you do. So carpal tunnel testing is not bad.
Yeah.
So that's low stimuli. The part that hurts is an ulnar neuropathy hurts more because you're moving up You get to the palmar responses, there's nothing there to get through, so they don't hurt very much. The tibial nerve hurts quite a bit behind the knee. So the carpal tunnels are pretty benign, I'd say. But check, maybe you can find out from the pictures. So just a couple words on motor neuron disease. So that was my last case, I think. So what can I say about motor neuron disease? So for motor neuron disease, you do need an EMG to diagnose it. It's the only test that we really have. You can corroborate that with the CPK, so creatine phosphokinase that's moderately elevated, around 300 or so, supports the diagnosis. The prognosis is very poor. We used to be reluctant to make the diagnosis because it has such a poor prognosis, and we kind of string people along, and there's been a culture change in trying to get the diagnosis as quickly as possible to get the patient, get the answer to them and move on and just live out the rest of their lives as best as they can. And I do sometimes use Riluzole, which is a medication to slow disease progression, although the data doesn't really convincingly show that it improves quality of life. On average, it prolongs life by 3 months. Most people die within 18 months to 36 months of diagnosis, so it does give you a little bit more time, but it's the worst part of the disease that's prolonged when you're already suffering a great deal. So my approach to motor neuron disease is that I talk a lot about death and dying, and trying to make the most of the time you have left, improving quality of life, which usually involves a PEG tube. People are quite opposed to that and think that this is unnecessarily prolonging suffering, but it actually, I think, improves quality of life, because when you have bulbar problems and you're chewing for 2 hours to get some nutrition in, then it's no longer fun to eat. And so I tell people, get the nutrition through the PEG and eat the chocolate for enjoyment. But don't, try to get through the steak, because it's just impossible. And so I think that's quite good. I do use sometimes breathing support, like CPAP at night, to give them more energy during the day. None of these things are to prolong life. They're all to improve quality of life while you're still alive. And the last thing you want to do is intubate these people, because they can live forever. If you want them, then taking that tube out is really difficult. So have that conversation with them really early, and that's usually they're under our care to prepare them for it, and try to get them away from trying every alternative therapy known to man. And I have a cousin, a second cousin, who has motor neuron disease in Germany. I'm German originally. Some people have wondered. Lived in the States. That's where. So he's been spending the last 3 years, basically, the whole money of the entire family has gone towards vitamin B12 injections, acupuncture, all sorts of antifungal medications, all these little bits of evidence here and there. It's completely destroyed the entire family, and he is no better for it. So it's that I think there's a good way to manage motor neuron disease. There's a good way to live out your life, getting hospice involved, and kind of focusing on family in a positive way, rather than clinging to these experimental things that just haven't shown to improve outcomes. And we'd be the first to want to prescribe something that saves our patients' lives, and to try and get that faith that we will tell them that we're not missing anything. We want to cure this disease, but we cannot, and not to spend all the energy on that. So those people, I think, do worse than the people who accept very early that actually, I will die from this, and I will focus on the bucket list. So I'm going to stop there. Now the 10 things to finish up, which is the summary of today. So I'm running these are by disease category. So TIA and stroke, I want everyone to remember these are medical emergencies because it's an opportunity for us to prevent this bad stroke before it happens, and we can prevent secondary complications by getting them under the care of qualified therapists quickly. We're rolling out the TIA tool nationally. Lots of places have other pathways, And you don't see these things often. I would encourage you, if you have a pathway or access to the tool, use it so that you can be sure you're providing best evidence care for your patient. If you cannot access it or aren't sure, in most DHBs, you should be able to ring the on-call neurologist or the on-call physician for some advice. So we want to get these people right. They don't all need to be seen. It's a difficult diagnosis. So call for help and err on the side of caution. For headache, I would want my GP to be pretty confident in diagnosing subarachnoid hemorrhage and space-occupying lesion, but I think most GPs I know have a sufficient degree of comfort with that. But if you don't, I'd like you to go and read an article about that once in a while to remind yourself. The other thing I would want my GP to know is the real risk of analgesic rebound headache, and to be wary of that and do everything you can to prevent this from happening to me in the first place, by not giving me prescriptions for codeine and reminding me not to overuse over-the-counter medications. And if I do struggle, to give me a prescription for a prophylactic. If I had epilepsy, I would want you to involve a specialist in choosing my drug. And if you don't involve a specialist, I'd want you to have some idea of what the drugs actually do, what the side effects do, and which drug would be the best drug for me. And if you don't, then that would be okay, but I'd like you to call a specialist or send me to one for advice. And I'd rather not have you check my drug levels unless you have a very good reason. If I had multiple sclerosis, I would want you to send me to a specialist. Especially when I have an exacerbation, because I wouldn't want to miss out on all the latest disease-modifying agents that I might have available that you may not be familiar with because you don't see a lot of people like me. And I would want you to call for help. If I have Parkinson's disease, by contrast, I'd be quite comfortable for you to prescribe me a dopamine agonist or a levodopa-type medication and see if that makes me better. And I may not need to see a specialist at all. If you feel pretty confident about the diagnosis, well, that's well controlled. I'd actually probably rather stay under your care than make the trip to the hospital where I might have to pay for parking. But I would want you to warn me of cognitive side effects to especially dopamine agonists. And if I have syncope, I don't want you to think neurology at all. I want you to think cardiology and send me to a cardiologist or consider other diagnoses, and certainly not send me to the TIA clinic. And I'd like you to know what the difference is between nerve conduction studies and EMG, and maybe tell me a little bit before I go to the specialist so I have an idea of what it is that I'm signing up to. And then I have my last slide as to how we can work effectively together. So there's lots of ways to involving specialists. I think that phone calls are really great. So if you have an acute problem, to ring up the neurologist. And a lot of are you able to ring a neurologist where you work for help? Sometimes. So it depends a little bit on the unit. It is disruptive. So when I'm on call for the acute wards at Wellington, this was last week. So I have a situation where I'm thrombolizing a patient, I'm standing in CT, I have a cardiology person calling me that there's somebody in status on the ward, I'm looking at a CT scan with somebody trying to decide on thrombolysis, and I have a GP calling me, asking me how to dose vitamin B12 injections. They're all very valuable, reasonable questions, but sometimes it's just more than I can cope with at any one given time, especially in the middle of an emergency. So it's not always easy to take the phone calls, but we endeavor to take them all. And the request I would have to my GPs in the area I work is that if I don't answer the phone, it's probably because I'm on the phone with somebody else, and please leave a message. Because there's nothing more anxiety provoking than getting a phone call that says unknown, because that's what the switchboard comes through. And then I have no idea who called, and the switchboard doesn't know, and it could be my stroke patient in ICU who's just bled. I don't know that it's you calling about a tingle in the left hand of a 32-year-old. So, or it may be something really serious, and you may think you're bothering me. So I would really like you to leave a message on my mobile and say, this is who I am, I'll call you back. Or never mind, I'll call you back in an hour, or actually it's resolved and I may or may not call you back. But just give me that comfort that I haven't missed something important. So that would be really great. But in general, phone calls are good for that. They are a little bit disruptive, and anything that could be put into a letter or an email has the advantage that I can look at it when I have actually the time to do that. So this is not to discourage phone calls, but just keep that in mind. So that's another way of doing it. Email access isn't great, and we're looking at ways to improve electronic questions, and so some DHBs are better than others. What you can do is you can send a letter, and we get that, we triage them electronically, and in Cap Coast we have a system now that I've just been starting to use called Note to GP. So I can actually go into our electronic system, pull up documentation, and send you an email. And it comes to you straight away, I'm told, pops up, it's like, thank you for your neurology referral. I think we're not going to see this person, but I'll set them up for a nerve conduction study. Call me back if this or this happens. And so I've been increasingly using that, so you get really quick feedback. And if I've missed something, you can call me or let me know there's something else. Otherwise, letters, we obviously, most of them result in issuing an appointment or a virtual clinic. So do you all get virtual clinic letters at times?
We can email a specialist that just ask for a comment.
Yeah.
Someone emailed a neurologist recently and got the letter back that they are not reimbursed for replying to emails, so they were going to do it. Or something like that.
Well, no, that's actually it's a very important issue because we don't. It's not just reimbursed, but it's not counted. So if I spend my day answering your emails and I don't see any first specialist assessments, it looks like I'm not producing anything and we're not getting any revenue for any of the work that I'm doing, and the DHB is paying me for getting no money from the Ministry of Health. So it is a challenge, and so that's how virtual clinics came about. So virtual clinics came about 5 years ago, and it was actually something we helped to initiate through Mid-Central, because I said, well, I don't want to just decline these referrals. I cannot see everyone. I want to send some advice at least back, but how can that be counted? And at first we just logged it. We just logged the referrals, so we knew how many they were, and then the ministry introduced a purchase unit for it. So, I mean, you don't give prescriptions, when people call in for refills, people charge for that, and, that's the same thing. So we're providing a free service that helps everyone because it improves flow through the system, you get faster advice, so we want to make sure that somehow that's recognized. So these are all things we're working on, and that's a result of it being slightly overused, So if you spend all your time answering emails and you cannot capture this in any way, and you don't get any payment for it, and you have no time to actually see patients, then that's a problem. And without that, we cannot say we need another neurologist to do this work. So that'll be the origin, but it's something that we're all facing, and it's a changing times. We need to get kind of with the program, and that's why it's really important that we all work together. So these are important things for us to know so that we can change it from the system.
So this is a virtual clinic?
Yeah, so virtual clinic is, if you sent me a letter, and so for example, headache patients, you a nice history of somebody with migraine who has some problem, and I have a really good idea of what you should do with that patient, but I really don't think I need to see the patient in clinic. I then write up a treatment plan and send it back to you. I tell my coders, log as virtual clinic. They actually generate an appointment for the patient on the system, a slot, 15-minute slot that gets counted so that it shows up at the funding division that a service was rendered. It also helps to provide a clinic letter that then goes into the notes for clinical documentation.
I find that very useful actually, because often you don't need them to be seen. And they get logged in and given an appointment. And I don't need an appointment, I just want some advice. If they read.
So we have done a survey of GPs in Mid-Central after that, and that's the response we got. Most people still wanted some people to be seen, obviously, and most people found it really helpful. But the problem is now GPs have started saying, I'm not really wanting the patient seen, I just want advice. And then it gets a little tricky, so is that still a clinic or is that just an email? And then there are people saying, well, you cannot count that as a virtual clinic because it's just a simple question you answered. I was like, well, if the patient shows up for a repeat, that's just a simple thing I thought.
Just count.
So, but it's just getting through that. So that's our problem. But if you want the service and refer for us, then that creates a demand. and then we can respond to that and write business cases around that.
So logistically here, CCDHP, we should write to you through Healthlink. We're saying this is a question rather than a, because at the moment we still can't ask for a question only, we still have to write a referral.
Have you not got the electronic?
Yeah, we do,
referrals?
but
Yeah,
we
so-
might write a question only.
What
We're
GPs
not doing that.
I do get things through that say advice only. I don't know how you do that, but some GPs send me a letter advice only, which is fine. I prefer just a referral that says, that may not need to be seen. I'd rather make the decision whether the patient needs to be seen or not, because if you write advice only, and then I think, well, I really kind of should see this person, and I feel like, well, that's not what they wanted. So, but
So you
these are,
potentially be able to use it as saying that's a 50-minute appointment.
Yeah.
Do what you want.
So we're working on that. So we need to increasingly work that way, don't we? Where they're your patients, you manage them, but we are here to support you. So that's how I see this evolving. It'll require some shifting of resources into primary care, but it just doesn't make a lot of sense for me to monitor somebody with epilepsy for 30 years when they have the same drug the whole time. So just making best use of our available resources. But I will say that with the neurology workforce, so we've done a survey of that, and we're actually only a third of the neurologists in New Zealand that we probably should have based on the neurological disease that's out there. So anything we can do to increase our efficiency is really helpful and make it better for our patients, and that includes things like pathways and electronic decision support. And then the use of the private sector, that will be my last comment, I think. So I don't do any private. I don't have a problem with private. And I think they actually fill a good, important niche. For example, your chronic headache patients that just struggle to meet the priority for being seen in public, which I think is kind of horrible because a lot of these people have very poor quality of life, but that's just the way it is. And if we're faced with somebody with chronic headaches versus someone who has an acute spinal cord lesion, we're just going to have to go with the spinal cord lesion. So these are really good patients to send to private. But in most DHBs, certainly in CAPCO, certainly in Mid-Central where I've worked, is if you have somebody acutely, if you think somebody needs to be seen urgently, we usually will bend over backwards to do that in public. And if they are acutely ill, it's a better place for them to be, because then we can access the imaging, and it causes problems when you send them into private with an acute problem, and then they need to be shifted into public, and then there's this queue jumping thing, and it just becomes politically quite difficult. So to me, the private sector is ideal for those people who don't meet access criteria to be seen in public, but people who are acutely ill and really need to see a neurologist, we can see them just as quickly in public generally as in private. And all of us have these acute clinics now that we can get people in, not all of them, I don't know if everyone does, but I believe most places can accommodate very quickly. So it may be dependent on your system, but it may have changed over the last 5 years. So I encourage you to look into what options you have. So I just thought I'd mention that. And it's the same doctors, right? Patients sometimes think they get better care in private, but it's the same doctors who work at the DHB. So it's not really, maybe better decor in the waiting room. But it's the speed of access that you get. And with an acute medical problem, you shouldn't have to worry about that. So neurology is very logical. Memorization, I would argue, isn't nearly as good as having a bit of an understanding of neuroanatomy, and I hopefully have demonstrated that today. And hopefully you'll have a bit of a more comfort with neuroanatomy after what we've been through today. Before you diagnose, try to localize to keep the back door open if you're wrong, because you may be wrong with your initial diagnosis, and it's easier to step back if you've given it thought in the first place to where it all could be. Most answers are in the history, and if you're concerned, think of losing a pathway and call us for help. And engage with your local neurologist to tell us what we can do to help you take better care of your patients. And that's it.
Thank you.